I'm Dr. Matthew Kim. Thanks for inviting me to participate in this. I'm an endocrinologist on staff at Brigham and Women's Hospital and Harvard Medical School. I'm also a medical informatician. I've been involved with NSRR since its inception and have seen it go through its evolution from a concept that was developed and then refined and then implemented and has evolved into the resource that's available today. And in my talk, I'm going to be covering some of the challenges that were encountered with regard to the heterogeneity of sleep data. So this is a diagram that shows the overall complexity of the types of data that are ingested and stored in NSRR. And you can see there are three principal sources of data. The richest source is polysomnography, multi-channel signal acquisition for sleep studies, but there's also quite a bit of data from actigraphy, accelerometer studies, and then a good amount of covariate data from patient-reported outcomes. And this is a diagram that was produced by Dr. Zhang, and you can see that there are different types of heterogeneity encountered with each of these data types, but there are actually some shared types of heterogeneity across these different data sources. And much of that has to do with some unique factors of sleep data itself pertaining to the semantics. So we're going to be talking about some of the challenges we encountered and our solutions to contending with these challenges, specifically related to semantic issues that stem from inconsistent sleep-wake terminology, evolving definitions of events, and complex variables. As someone who came to this with a background in clinical research that was predominantly in the field of endocrinology metabolism, I've been struck by the complexity of trying to describe sleep research data. There's a lot of focus on intervals in describing different sleep disorders and responses to interventions. And a lot of that really depends on precise specification of timing. And in first encountering the way that different variables have been reported in these data sets, it was interesting to see that there was a lot of inconsistency, actually quite a bit of ambiguity in referring to intervals. In our first pass at looking at a lot of these data sets, we soon discovered that the terms sleep time, sleep duration, and sleep period were being used interchangeably between data sets and in a couple of instances within data sets. Leading to some potential confusion. It made it difficult to understand whether these terms were referring to the same types of intervals. So one of the first things that we endeavored to do was to try to standardize this terminology so we could be sure that we were talking about the same things when comparing variables between data sets. And so the first effort we took was to standardize the actual terms to describe points in time and intervals of time. And so we decided we'd say that time refers to a specific point in time. A period refers to a continuous interval between two specific time points. And a duration is referred to as the sum of the lengths of multiple intervals describing a specific start or condition. And this is all categorized within specific designations. So you can see these are what we've selected as standardized times, standardized periods, and a standardized duration. But it's probably best illustrated with this sleep architecture schema. This was originally developed by Dr. Zhang, was subsequently refined with the input of subject matter experts and users. And you can see this very elegantly depicts what we're referring to when we use these designations. There's a start time for each period, an end time for each period, definition of the interval that covers that period, and then importantly, especially when considering the depth of information that's available from sleep studies, the ability to define different types of intervals within intervals. You can see there are wake after sleep onset intervals that occur within what's called the sleep duration. And so this has gone a long ways towards making sure that we're actually referring to the same things when we're trying to harmonize and curate variables and data sets that have been uploaded to NSRR. Another source of heterogeneity has to do with the evolution of definitions. So there's a large focus in studying sleep-disordered breathing on apnea-hypopnea indexes. Apneas are the cessation of airflow, but hypopneas have turned out to be something that's been defined in different ways at different points in time. You can see these are the ASM guidelines on scoring rules to identify hypopneas. And starting in 1999, there was an original definition based on a greater than 50% flow reduction with greater than 3% desaturation or arousal with an event lasting 10 seconds or longer. But you can see this definition has evolved over time. There was an update in 2007 that changed the flow reduction and the desaturation. There was proposal of an alternative definition. Both of these were reassessed and reassigned again in 2012. And then in 2015, there was a pediatric definition added. So in looking at the data from sleep studies, the question always comes up as to which of these definitions are being used to identify hypopneas. Are they consistent definitions? Do they change during the course of a study or at different points in time? And then this leads into what's probably the greatest source of heterogeneity in sleep data, which is the complexity of the variables. And again, as someone who came from a background in endocrine and metabolic research, I could say I was at first pass very struck by the complexity of sleep data variables, used to dealing with things like plasma glucose and intimal medial thickness, very concrete, very translatable definitions. But you can see this is how complex and conditional some of the variables that we've had to work with can get to be. This is an actigraphy variable. Total number of days with naps greater than equal to 15 minutes in the entire actigraphy recording period reported for non-work days from actigraphy. Many conditions, many thresholds, even more complex. This is from a sleep study, apneas of polysomnogram, apneas with no oxygen desaturation threshold used, and with or without arousal, plus hypopneas with greater than 50% flow reduction and greater than 4% oxygen desaturation, and with or without arousal per hour of sleep from a type 3 home sleep test. And even in what we usually consider to be fairly less complex variables from survey instruments or medical history, you can see we can have a history of myocardial infarction based on provider documented record review, not adjudicated. So very complicated variables. And when we originally envisioned how the NSRR was going to be structured, the first plan was to develop a sleep domain ontology, to have a very formal ontology that included classes and attributes and relationships that would be extended to cover the full range of data available through the NSRR. And once this project started, about 3 or 4 months into trying to develop an ontology, we realized it was going to be very difficult to develop and even more difficult to implement. It was very unwieldy. It seemed like it would be very difficult to extend. It seemed like whenever we tried to adapt this to existing data sets, almost everything became an edge case, which almost made it a bit redundant to have an ontology in the first place. So we actually had to abandon this approach about 6 months into development of the NSRR. And as a workable alternative, we decided to develop a canonical data dictionary. So in order to do this, we abstracted variables from foundational data sets. Most of this came from the Sleep Heart Health Study. And then we edited those variables to generate canonical terms that provided precise definitions of origins, thresholds, and statuses. And then we compiled those into a curated canonical data dictionary. And we linked terms in that data dictionary to variables in each data set as they were added to NSRR, so we could provide a node of connection for cross-cohort queries. This was a lot of work up front, but it proved to be something we could implement fairly rapidly, and it actually allowed us to start ingesting data sets into NSRR. We found we needed more richness of labeling, so eventually these canonical terms were appended with additional metadata elements designating the source, timing, equipment, and collection method for different variables. And again, this proved to be feasible. It worked during the initial iteration of NSRR, but it was fairly labor intensive and it was very difficult to scale. Each time a new data set would be added, we'd have to comb through it. to see if there were new or different terms that would have to be translated into new canonical terms. And then we'd have to review existing data sets to see whether terms that had already been labeled might be more appropriately labeled with a new canonical term. So it seemed like this was workable, but something that would be challenging to continue on a long-term basis. And so this eventually led us to develop an innovation that we call a compositional terminology. And the actual inspiration for this came from when I was studying for clinical informatics board certification. And there was a lot of focus on different coding schemes, and I became interested in the SNOMED CT controlled terminology, and actually the idea of post-coordination, the idea that you can have different tags and labels for diagnoses and modifiers, but that you could combine those tags and labels to generate a much richer definition within a single designation. And so this is kind of a simplified version of the theory behind this. So if you had multiple data points from different studies that were just designated as a history of myocardial infarction, that could mean different things in different contexts. It could be a history that was reported by a subject on a questionnaire. It could be a history that was abstracted from a subject during an interview, or it could be a history that was actually submitted by a provider reviewing medical records. And probably the most verifiable version of this would be a provider reviewing records with some form of adjudication. This would be the most substantiated version of this. But if you just looked at the term history of myocardial infarction, you wouldn't know what level of verification was provided for each of these. But what if it were possible to decompose this? What if we were able to take each of the different conditions and elements of these variables and break them down into different types, and then have different component labels for each of these types? So you could refer to the condition itself, you could refer to the timing of when it was obtained, the source of the data, the method of collection of data, and whether validation was provided or not. And then if you recombine these components, then you'd have a much richer definition of what these variables actually mean. You'd have a label or a tag that you could apply to this variable that would allow you to understand this without having to dive into study documentation and an understanding of the underlying protocol. And so we've been able to adapt this to sleep research data. And this has involved developing this scheme. Again, a lot of this is work that's been promoted by Dr. Zhang. And you can see this involves developing these different component designations. So we have a root component that's based on combination of modifiers, data types, and events, and then additional modifiers that can be added to the root component. And when this is all combined together, we've been able to develop these labels that provide a rich description of the actual variables themselves. This is an example. You can see this looks like it's basically just a nonsensical label. But when we break this down, when we parse it, we can see we can actually abstract these different components. We can see that this variable refers to a total apnea and hypopnea index, that the apneas are defined as total apneas with no oxygen desaturation, with or without arousal. The hypopneas are defined based on this definition with 50% airflow reduction and greater than 3% oxygen desaturation, and that all this data was collected using a type 2 home sleep test. So you can see a very rich source of data from a label. And then this shows kind of the value and utility of this. Once these labels have been generated, they can be parsed and they can be sorted and reassorted. This is a proof of concept application also developed by Dr. Zhang. And you can see it allows us to sort through and categorize and combine and recombine different variables based on each of these component elements. So in summary, just to kind of review issues with heterogeneity and our approaches to solving those, I'd like to say that proactive disambiguation of imprecise terminology helps to promote effective harmonization of clinical research variables. And a compositional approach to the labeling of complex terms functions as a practical and scalable method of incorporating semantic markup that enhances the findability and comparability of clinical research variables. And ultimately, this approach could actually be readily extrapolated for use within and across other domains. It would be possible to develop tools and instruments that would allow people uploading data sets to label and mark up variables on their own. That would really go a long way towards simplifying harmonization and curation.